Now I'd like to request our next speaker, Dr. Mohammad Kamal Parvez, to come to the stage and deliver his El Kappa syndrome in adults, a rare case report. Dr. Kamal Parvez.
Honorable Chairperson, respected teachers and distinguished audience, Assalamu alaikum. I am Dr. Mohammad Kamal Parvez, a Phase B resident from Sir Solimullah Medical College, going to present my case. Anomalous origin of left coronary artery from the pulmonary artery, that is El Kappa syndrome in adults. Basically, we are going to discuss the anomalies of the coronary artery. Anomalies of the coronary artery, three types. It may be anomalies in the origin, it may be anomalies in their course, or it may be anomalies in their termination. When anomalies in the origin, there may be anomalies pulmonary origin or anomalies aortic origin, there may be high take-up or low take-up. In all these conditions, you have technical difficulty to engage the catheter. So El Kappa is also called blunt white garland syndrome, and it is a very rare disease. 1 in 3 lakh incidence, and it is more extremely rare in adult. When an adult patient is diagnosed with El Kappa syndrome, I think both the patient and both the physicians are lucky. The patient is lucky in that because he or she has the probability to die, 90% probability of die within the 1 year without treatment. So when a patient with El Kappa, I think he or she is lucky. And the patient survived in adult due to extensive development of collateral between right and left collateral system. Without the extensive development of collateral, it is not possible survival. And our patient, 40-year-old lady without any risk factor for coronary artery disease, presented with exertional chest pain, that is CCS class 2 for 1 year, without any history of palpitation, syncope, pre-syncope, or shortness of breath. You know this type of patients are increased risk of sudden cardiac death. And when physical examination, her vital and other examination was within normal limits. And her ECG showed, you see the LVS with eastern pattern in the limb leads, and there is flattening of the TOF, V5 and V6 with left axis deviation. When we have done an echo, the zoomed image of the left parasternal short axis at the level of great vessel, you see the right coronary sinus is bulged to the right ventricle, and the same image in the color flow imaging, you see blood is flowing through the right coronary artery and it is bulged to the RV, and the right coronary it is dilated. It is the still image. There is the origin of right coronary is dilated. And when we have done the color flow imaging at the left parasternal short axis, at the level of great vessel, you see abnormal turbulence flow. This is the turbulence flow in the proximal part of the pulmonary artery. It is the still image, the turbulence blood flow. It is the aorta. And the color flow imaging apical 3 chamber, there is eccentric MR. And now the question is there any unique echocardiograph diagnostic parameter for El Kappa in adult? According a case report published in the European Journal of Cardiology, they show the increased systolic coronary blood flow in the interventricular septum in the pulse wave Doppler is diagnostic, and this report is supported by very other few case reports. And you will find there is multiple turbulent blood flow in the ventricular septum, sometimes may confuse with the VHD. There are few case reports this turbulent blood flow in adult is misdiagnosed as VHD. And these are already discussed. If you want to see the origin of coronary artery, we have see the root, aortic short root axis. But in adult, it is very difficult to find the origin of the coronary arteries if it is normal. But in children, due to their anatomy, it may be easily diagnosed. And you will not find the LCA ostium. And when to find the LCA ostium, you have to go the parasternal short axis at the pulmonary artery level. Now we see the color flow imaging apical fourth chamber. You see the turbulence blood flow in the interventricular septum. This is the turbulence blood flow in the and this is the still image. You see turbulence blood flow interventricular septum. When we put the pulse wave through the interventricular septum, you see the predominant systolic flow over the coronary arteries. And so we have done a coronary angiogram. The LO cranial wave will show that the RCA is dilated, tortuous, and ectatic vessel. We tried to find out the LCA sinus, but we could not find, rather than it was repeatedly going to RCA sinus. So we shift our route from the transradial to the transfemoral route for selective angiogram of the left coronary sinus through the JL catheter. And when we put the JL catheter selectively, you see the left coronary sinus is empty and there is no origin of the left coronary. And so we have done through pictal root aortogram, you see there is right coronary artery is dilated, hugely dilated, ectatic, and right coronary artery is predominant, and there is retrograde filling of the left coronary system. And probably it is the pulmonary, going to the pulmonary artery. Again, the pictal, another view, you see the same thing, and you see the extensive collateral between right and left system. It is the still image, you can see the extensive collateral, and probably this is the retrograde pulmonary artery. And we have done also CT pulmonary angiogram with pulmonary angiogram. We showed the origin of the right coronary artery from the aorta and the left coronary artery from the pulmonary artery. And this is 3D reconstruction of the artery, clearly shown the origin of the coronary arteries. Now the pathophysiology, to understand the pathophysiology, we need to think the pressure over the aorta and pressure of the pulmonary. During the neonatal period and up to the 3 months, pressure of the pulmonary artery and aorta is same. So there is antegrade blood flow. But after 3 months, pressure in the pulmonary artery falls and there is retrograde blood flow from left coronary artery to right coronary artery. And if there is no collateral, this patient will die within 1 year. And if patient survives, there is extensive development in collateral and reversal of the shock from the LCA to pulmonary artery. This is already discussed. And dilated coronary artery differentials are atherosclerosis, very common, Takaysu arteritis, Kawasaki disease, coronary sinus fistula, and coronary cameral fistula. And, regarding the treatment option, when L-kappa present, whether it is symptomatic or asymptomatic, it should be treated. Why the asymptomatic L-kappa should be treated? Because this patient has very high chance of sudden cardiac death. And only 18% patient who died, they have previous symptom. But in case of R-kappa, right coronary from the pulmonary artery, if it is symptomatic, it should be treated. And if it is asymptomatic with myocardial dysfunction, it should be treated class 2 indication. And treatment is treatment of the two coronary artery system is the treatment option, and pressure of the CABG with ligation is the treatment option. There is various treatment option. This is the two placement CABG and ligation. It is Takaysu procedure in this coronary baton transfer. And this is my reference, and I acknowledge my professor, Dr. Khalikum Jaman sir, and Dr. Mohammad Sarai Alam sir for their support. Without support, it is not possible. And now, take home message is, আজ দুজনা দুটি পথ গেছে বেঁকে দুটি দিকে বেঁকে গেছে তোমার এ পথ আলোয় ভরানো জানি আমার এ পথ আধারে আছে ঢেকে রাইট করোনারি লেফট করোনারি দুটো ভিন্ন দিকে চলে গেছে সেপারেট ওরাজিন রাইট করোনারি আলোয় ভরা রক্তে ভরা এবং লেফট করোনারিতে হচ্ছে ইস্কেমিয়া এই পেশেন্ট সার্ভাইভ করবে যদি রাইট করোনারি এবং লেফট করোনারির মধ্যে এক্সটেন্সিভ কোলেট্রাল হয় থ্যাংক ইউ
Thank you very much, Dr. Kamal Parvez, for his beautiful lecture. Now, I would like to request our audience to have any questions. This is for the other 4 minutes time. And next, I would like to request our discussants and judges to have any questions or not.
Did you try to, in this case, যদিও retrograde খুব easily দেখা গেছে, did you try to any way cannulate pulmonary artery and do another extra exposure?
No, we did not try to cannulate because it was our first case unaware, and there is high chance of complication if you cannulate to the pulmonary artery, and we are not known what it might be. It may be aortic origin also.
You have shown in your echo, according along the interventricular septum, there is a mosaic flow.
Yes, mosaic
What
flow.
does it mean?
It is the extensive collaterals over the extensive collateral producing the turbulent flow in the interventricular septum.
Now,
Extensive collateral between the LCA and RCA.
how can we get clue that it is due to Al-Kappa?
Oh, according to the European Journal Ecology, if we put the pulse wave Doppler, there is systolic flow. On the other hand, other coronary anomalies, there is diastolic flow predominant. But in case of Al-Kappa, there will be systolic coronary flow.
It's
Or
predominant.
pulse wave Doppler. In this way, we can differentiate Al-Kappa from other coronary anomalies. Like
Thank you.
coronary femoral fistula, there will be diastolic flow.
Dr.
Thank
Kamal
you.
Parvez,
Thank you very-
please, whether any other record of Al-Kappa in our country, one point. Second point is that most of the patients should die in their infancy or early childhood. So how could possible to survive up to this period? Thank you.
Because there is development of the extensive collateral between the right coronary and left coronary artery. And there may be also pulmonary pressure high, so that the retrograde flow become less, and there may be ostial stenosis in the pulmonary artery, preventing the retrograde blood flow, and there are a few hypotheses. There may be bronchial coronary connection. Last BIT session I see is a moments are present a case of Al-Kappa syndrome.
Okay, time is up. Thank you, Dr. Kamal Parvez. Now I would like to
Thank you, sir.
request our next speaker, Dr. Mohammad Sajidul Islam, to come over the dais and deliver his speech